welcome to Health Check on GH Today. I am Nanama Anabempong, and today we are at the Shape Healthcare Specialist Medical Center, and we are going to be speaking with Dr. Promise Sefoga about the importance of antenatal and the delivery process. We'll be right back. Dr. Promise, you're welcome.
Thank you.
So today we're here to speak to you about the importance of antenatal and delivery processes. What exactly is antenatal?
Good. So, antenatal care is that period from the time a woman conceives through to the time she delivers. So, that systematic review we take her through initially, maybe every 2 weeks and every month. Then when the time is getting closer, based on the risk or the profile of the woman's pregnancy, we may verify the number of the intervals between the visits. Basically, keep a close eye on the woman. How is her nutrition? How is her blood pressure? How is her weight gain? How is baby also coming out? Baby's position, baby's growth, baby's size, heartbeat, all of that. And then making sure the woman does not lack anything by way of supplement, or the woman does not suffer any infections that could affect the baby or affect the mother or both. So that systematic review and treatment that we do for all pregnant women is what constitutes antenatal care.
So what exactly are you looking for when you are doing the scan, for example?
Good. So the scan is one of the things we do. The very first scan, once the woman has missed her period, we say come up to the hospital, because we need to do one early scan before the 8th week to be able to see where the pregnancy is. Pregnancies can be located inside the womb, or they could be found outside. If they are located inside the womb, that is normal. Occasionally they can go and be placed inside a tube, or even on the ovary, or anywhere in the abdomen, instead of being at the right place inside the womb. Anything outside the womb is called ectopic. Now, the ectopic pregnancy, you can imagine the pregnancy is growing in this thin part of the womb. As it gets a little big, the womb, the tube will stretch. It stretches till it can't contain anymore, then it bursts.
Wow.
Then the woman bleeds inside the tummy. If she doesn't get surgery promptly, she's going to die. So that early scan is important to make sure, oh yes, she's pregnant, it's at the right place. Okay. And so once that has been established, as the pregnancy also goes on, we do a whole lot of labs. What's the woman's blood group? What's her sickling status? Is she sickle cell, AS, SC, SS? It all comes with various risk levels for the pregnancy, for both the mother and the baby. Then what is her hemoglobin level, her blood level? Is it enough to carry her through pregnancy, or is it too low, so she needs to start taking supplement to make more blood? Are there any worm infestation in the system? We correct it. Is there malaria? We correct that, because malaria goes to occupy the placenta and makes the mother's nutrients unavailable to the baby. The mother will be anemic, baby will not get enough energy, nutrients to grow, baby will come out smaller than expected. So we do all these things. And then most importantly these days, we are seeing this problem of high blood pressure during pregnancy. So in the greater Accra region of Ghana, for instance, hypertension during pregnancy is the leading cause of maternal mortality.
Wow.
Women dying as a result of pregnancy is as a result of high blood pressure during pregnancy and its complications. So during the antenatal, we check your blood pressure every time, and we check your urine. Are you leaking protein in the urine? That will say, okay, blood pressure is high, it's affecting the kidneys. So it becomes something we call pre-eclampsia. Sometimes it gets so bad we have to end the pregnancy in order to safeguard the woman's life. So all these, checking for diabetes during pregnancy, and also checking when we do the scan later on. There's one scan we do around 18 to 22 weeks. We call it the fetal anomaly scan, where we examine the entire baby from head to toe. Look at the brain, look at the head. Is the head shaped well? Is the brain okay? Is there water in the brain? Are the spinal cord okay? Are the kidneys okay? Are the lungs okay? How about the heart? Is there a hole in the heart? Are the legs all okay? Is there any problem with the intestine? We do that detailed scan. And so if there's any major abnormality with the baby, we now sit down to discuss. Baby is coming up with no brain in the head, only water. Do you really want to carry the baby to term and deliver, and baby just comes out and dies off? Or would you have us terminating? Then we discuss these things. Or there are some conditions that will require that once baby comes, baby goes through surgery to correct. So we need to know all these things to prepare even the mode of delivery, and if there's going to be any intervention soon after delivery. And then as the pregnancy progresses, we do another detailed scan later on to assess the weight of the baby and how the baby has position. Baby, we want preferably the head to be down and the legs to be up. It makes labor and delivery smoother. So we check for all that. Or is the baby rather coming with the legs? If that is it, is the weight okay? Is it portable enough that when the legs come, the head will not be stuck? So we make all decisions based on the scan findings. Is the water level okay? Is the placenta okay at the right place? Or is it at a place that mother is likely to bleed before, during, or after delivery? Then we can prepare for all of that.
So if the baby is breech with the legs down, is it still possible to have a natural birth?
Yes, it is.
I didn't know.
Yes, it is. Then it comes to the issue of, has the woman had a previous cesarean delivery? If she's had a previous cesarean delivery, then it will be risky to allow the breech to deliver. If not, and then the baby's size is not too big, more than 3.2 kilograms for instance, we would say it is okay to have it come. But if it's bigger than that, you can imagine that when the head comes first, the head is able to open the birth canal for the rest of the body to squeeze through. If the legs and the buttock comes first, then it doesn't open it adequately for the big head to come through. And a few unfortunate situations, the woman has been told that the baby is a little big, it's coming with a buttock, let us rather do a planned cesarean. Woman says no, 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 no. My pastor says no knife to touch my body. So she does not come back for the cesarean. She goes into labor, attempts to deliver at home or in the church house. The baby's legs and the buttock, all the body has come, it's got to the neck and it's stuck there. You know, there's very little you can do. Unfortunately, baby died. And these things happen. So we use the size of the baby plus other parameters to decide, can this woman deliver the breech or we have to deliver through cesarean section?
But can somebody choose themselves that, okay, I've decided that I want to do this type of birth? What are the types of births that are available to women?
I mean, largely we have the spontaneous vaginal delivery, which commonly we do with a woman in the lying down position. There's other types where they can deliver in water, we call it water birth. Or there's some, in other areas, there's a delivery stool or birthing stool the woman sits on and the baby pops out. But commonly, the most common is the normal spontaneous vaginal delivery, lying down, or the cesarean. Cesarean becomes necessary for reasons that will make that most appropriate for either the baby's well-being or the mother or both of them. For instance, like we said, if the baby is coming with a buttock and the baby is big, cesarean is safer. If the baby is so tiny and we are afraid that the force of labor contractions might compromise the baby's heartbeat, cesarean. Or if we think she can have a normal delivery, but in the course of labor there's something going wrong, baby's heart rate is dropping, it means that baby cannot go through the stress of labor, we call it fetal distress, then we stop the labor and go ahead and do cesarean. Or sometimes we use a machine to extract the baby, we call it vacuum extractor, provided the mouth of the womb, we call it cervix, has opened up to a point that the baby can come through.
Okay.
So the cesarean can either be a planned one, we call it elective cesarean, or an emergency.
Okay.
So various reasons will necessitate one or the other.
But it seems many women now are choosing to do a cesarean because they don't want their vagina to open up, to get loose and those kind of things. Is that something you have heard of, and is that something that you sway women against?
Right. I mean, I have heard a few women talk about that, so maybe you are hearing more of that than I am hearing, which is okay. But the truth is that when a woman delivers vaginally, there is a little bit of loosening, but most of that would return to normal with time. And of course, we teach them some exercises to do, the Kegel exercise and other things, to try and get a pelvic muscle tone back. Of course, with repeated deliveries, there may be some residual loosening. If it is to the extent that it is creating problem with quality of sexual life, there are some minor surgical procedures we do to correct it if it becomes necessary.
Okay.
But every woman also has the liberty to choose how they want to deliver. From our point of view, we would say, because cesarean is surgery, it goes with some risks of surgery. So if it's not absolutely necessary, I'll probably say no. But of course, mine is just to present you the facts and guide you to decide. So I'll say, no, you can have a normal delivery. But if the woman say, no, doc, I prefer cesarean, we go ahead, knowing the kind of risk you are exposing yourself to, and then being fully aware, then you consent to it. Yeah.
Now, I have not been through pregnancy myself yet.
Hopefully soon.
Yes. But I was told that cutting and things like that. It sounds very painful. Yeah. So what happens? Is it every woman that has to be cut, or some, or what's?
Great. So the cutting, we call it episiotomy. So basically, what it does is during some of the delivery, the vaginal outlet is a little tight for the baby's head to come through. So we do a little bit of cut here at the lower part just to widen it up a little bit. Of course, we inject the place to make sure we block every pain before we do, and there's a specialized scissors we use to cut that after we have injected to make sure there is no pain. Okay. Labor itself is painful, I must say. So most of the time, once we block the pain, this is usually not a big deal. And of course, it's not every woman who will require episiotomy. We give it based on appropriate professional needs assessment. If the baby's head is come and it goes back, comes and it goes back, it means this woman might need a bit of help to widen it and pull it comes out, right? And pain control in labor, it's something we try as much as possible to do. But labor pain, it's so intense that sometimes you do so much and the woman still feels it. But there is what we call epidural, which is a form of regional anesthesia. We put an injection at the back and we keep topping up. That deals with the pain quite well, and it's available in most institutions on demand.
What's the danger with that? Because I heard of some instances of paralysis and those kinds of things with
so paralysis after delivery hasn't got necessarily to do with epidural anesthesia. No, it's something that can happen because the pelvic area gets to go through so much trauma in the course of delivery in certain women that the joint gets a little loose or open up, so it's not stable, might require a bit of physiotherapy. In the worst scenario, some people can get temporary paralyzed, and then that gets corrected. But not from the epidural.
Great, that's good to know, because I think a lot of women have also heard that kind of thing and they need that to be corrected. But going back, you mentioned about the breech. I also saw something that a doctor manipulated the baby to come back with the head. Is that a difficult procedure?
It's not a difficult procedure. It is called external cephalic version. You want to say that after me?
Say
external
cephalic.
Cephalic. It means you're trying to externally bring the head down. External cephalic version.
External cephalic version.
ECV. So it's something we do if we realize that the baby is breech, but there is no contraindication. The woman has not had cesarean before, the placenta is at the right place, there's enough water around the baby. We try to do that, to bring the buttock up so that the head goes down so the baby can come down. We do that. Just that is the skills that not everybody has, and then it goes with some risk. When you're doing that, you have to make sure the theater is ready, so that in the process the placenta may start peeling off, and then that is fetal distress. You have to quickly go in and do cesarean to get a baby out, and so you need to satisfy certain criteria before you attempt doing that.
How long does it usually take?
Oh, it's a 5-10 minute procedure.
Okay.
Yeah.
Okay.
You do it at the OPD, put a bit of powder on the tummy so your hand is free enough to move around, and then you do it. Do. Yeah. Sometimes you do it and then it goes back. Yeah. Especially if you do it too early. So we do it between 34 to 36 weeks, whether the woman has delivered before or this is her first time.
So once you've done it, because my thought was that you are doing it just before she's about to deliver, but it's not like that.
There are some that we do it and then we start you on medicine to induce the labor.
Okay.
Otherwise, we do it and then you go back home and come back. So like I said, around 34 to 36 weeks. Normal delivery is supposed to happen at about 40 weeks.
Sure.
Yeah.
You mentioned earlier too about early labor, the Braxton Hicks.
Yes.
What can you tell us about that?
So Braxton Hicks is just the regular contraction that a pregnant woman feels when she's in the third trimester. You feel this hardening of the tummy and then it relaxes, but that is painless. The contractions of labor are painful, so that's the difference. So Braxton Hicks, you feel the hardness from time to time, but it does not come with pain, just a bit of pressure. But once you're feeling that painful contraction intermittently before 37 weeks, you are having preterm contractions. You need to report to the hospital. There are certain causes of that. It could be some infection, it could be malaria, it could be something else wrong. Then we figure it out and deal with it and see if we can stop the contractions so that pregnancies can carry on till the babies attain full term. If all our efforts fail, then you deliver preterm. Depending on how far removed from term the baby is, baby might need to be put in the incubator to develop well, maintain the temperature until baby can do well on their own.
Dr. Promise, thank you so very much for your time.
You're welcome.
That has been me, Nanama Anna Bempong, on Health Check today. We were talking about the importance of antenatal and the delivery options that you have. See you again next time.